Oh, I'm a bit short. Shall I put these down? That's better. Okay. Okay, well, I'm Sophie, and I'm the Chief Exec of Myeloma UK, and thank you, Louise. That was an amazing talk. And thank you very much for the invitation to speak here today as part of your 25th celebrations. We had our 25th last year, so I think it's been a great 25 years working together. I think most of you know that we are the only patient organisation that's focused entirely on myeloma in this country, and our ultimate aim has always been to find a cure. And I hope what we'll talk a bit about today is just what that means and how that's changing over time. We fund research, we work with patients to make sure that we get access to the right treatments at the right time, and we provide a lot of direct support services. So 25 years, a lot has changed over 25 years, and I would like to think that over that time, Myeloma UK and UKMS have been really good partners working together to similar ends. A lot has changed over that 25 years. Survival times have quadrupled, and we've gone from having no bespoke treatments to the amazing and complex menu of options that Neil took us through at the start of the day. But challenges still remain. For high-risk patients, extended remission periods remain a pipe dream. And for those who are living longer, that difficult pathway can be complex to navigate. And as Louise has said, drugs are tough physically and psychologically. One size no longer fits all. And I would agree very much with what Martin said about needing to reflect the heterogeneity of the experience of people living with myeloma. And so because of that, last year we did quite an extensive piece of engagement across the myeloma community. Before I took on this job, I worked predominantly in the disability sector, supporting autistic people and blind people at the National Autistic Society and RNIB. And one of the great mantras in the disability world is nothing about us without us. So it is really important that for us, people living with and affected by myeloma are at the absolute heart of what we do. And what we wanted to do with this engagement work is to understand, sort of 25 years on, how things are changing. What are the new and emerging needs, given the great improvements that have happened, but the challenges that still exist? And we spoke to over 700 patients, and we spoke to experts, both internationally and in the UK. And basically, our focus now is threefold. That middle column, which we're calling Treating Myeloma, is probably what historically you've known us best for. So we will carry on funding research, doing our own in-house applied health research, and our advocacy work to make sure that every myeloma patient gets the treatment that they need in this country across the nations of the United Kingdom. But things are changing. Yes? So yes, we need to carry on and focus on that, and increasingly looking at high risk and how we stratify and make a more personalised approach to treatment. The other thing, though, is, and I think Louise's talk really brought this out, if you look at our right-hand column there, which is living well with myeloma, we do have people living longer. And a lot of what Sarah Henshaw spoke to and what Gordon spoke to about frailty fits into this box. The physical impact of living longer and living longer on treatment, the psychological impact of living with a relapsing, remitting condition. All of those things are things that we need to understand more, and we need to understand that from a patient perspective. And this year we launched our first survivorship research grant call, and I'm really, really excited to see what will come out of that. And then finally, our left-hand column. Is it just possible that we could prevent myeloma? Could we, through a combination of understanding precursor conditions and thinking about what interventions might be possible, actually get to a point where we could prevent full-blown myeloma and banish it from our experience? So really what we are moving towards is a very, very patient-centred but whole life cycle approach, looking at prevention, looking at treatment, and looking at living well, so that together we are the cure, all of us in this room. And whether that cure means a functional cure with people living longer and living better, whether that cure actually means prevention, or whether that cure means more personalised treatments for patients living with active myeloma. All of those things potentially could lead us to that ultimate aim of cure that we all in this room want, I know. So with that, I'm going to just hand you over to Sheila to talk a little bit about some of the things we have on at the moment.
Thank you, Sophie. The heading for our talk today was Patient Priorities and Inclusion, and everything we do is led by people affected by myeloma, and we aim to be representative of all backgrounds and experiences. That's a core part of our strategy. So I'm now going to talk about how we are putting those strategic objectives into practice, and it's a lot to get through in the time, so my apologies if I really rattle through it. We wanted to strike a balance between talking about how we keep those patient needs and priorities at the heart of our work, but at the same time not miss the opportunity of making sure that all of you in this room and at home understand the breadth of work that we do. So I'm going to touch first of all on research. Oh, except my clicker. I think I tried to go too fast. There we go. So our research programmes run across broadly 3 different sort of topics. We have our laboratory and translational research. We work in clinical trials through our partnership with the UKMRA and the Leeds Clinical Trial Unit. And we also, quite unusually for a charity like ours, have our own in-house applied health research team. Now, I could easily spend twice my allotted time just talking about the first 2 buckets of our research. But today, because of the topic of patient priorities, I've decided to focus on our applied health research. Because if Myeloma UK is about anything, it is about that connection we have with patients. Patients trust us with their experiences, they trust us with their insight, and we have the ability to really take that patient experience, both individually and aggregated, into the wider environment. And what we do in applied health research is absolutely key to that. As Sophie said, we have completed a really significant piece of work where we ran 2 surveys on unmet and emerging needs. Across the 2 surveys, we received 1,800 responses. And when we presented some of that data at EHAN, we're presenting at ASH also, people kept saying, so where did you get your data from? And we said, well, it's our data, we collected it. And then they would say, no, where did you get your data from? People couldn't quite fathom that we were collecting data on that sort of scale. We have our patient and carer research panel, now 100 members strong. They are trained and supported to review research proposals, protocols, patient information. So if you have a research project, please do come and talk to our patient carer research panel. We design and deliver PPI through focus groups, through workshops. We conduct our own qualitative research, sometimes in partnership with other grant holders, and I'm delighted to say that we are a partner on some significant grants at the moment, but they haven't been announced yet, so that will have to wait for another day before we talk about that. So what does gathering all of this insight mean in practice? And I am hugely reassured that what I have here matches a lot of what Louise has said, so clearly we've done something right. For us, personalisation is absolutely key. It's what patients want, it's how we move forward, and fundamental to that is getting MRD and diagnostics working together. Those are the building blocks for the future and for a future of personalisation. So we'll be taking our insight and making those arguments and looking for investment opportunities. We are very focused on treatment burden, and that involves things like dialing down the decks. Can we do better with less dexamethasone? Looking at dose de-escalation. And in quality of life, that issue of psychological support. That came across in our unmet needs survey very, very clearly, that there isn't enough out there for psychological support. Also looking at best supportive care, Very interesting that Martin raised the issue of peripheral neuropathy. We know how distressing that is to patients. Fatigue, diarrhea, again, were two things that came across really clearly in our unmet needs survey. So what can we do to make sure that we are investing in improving that best supportive care? I was absolutely fascinated by what Kerry said about the fact that there's no problem accessing IVIG in Wales, because that is absolutely not what I hear about England. And with a future of bispecifics, we've got to get to a place where everybody has no problem accessing IVIG. And if they can do it in Wales, I don't see why they can't do it somewhere else. The next way in which we prioritise patients is in our patient advocacy work, our policy work. So we work with decision makers in the NHS, in government, and very importantly in the drug approval bodies. This talk is going to focus on the work that we do in drug approval. My apologies, this is a little bit of a long list of narrative here. Key points are we advocate for patients in every single drug approval across the UK, Scottish Medicines Consortium and at NICE. We are the only organisation that does that. We do that in partnership with the UKMS for NICE. This involves us engaging with industry. So underneath the formal NICE process, we will have lots of meetings with industry talking about what is your positioning, what is your data, what is your value proposition, where are your uncertainties, and is there anything that we as a patient group can do to fill some of those gaps? How do we do that? We do it through gathering patient evidence. We do that through surveys, focus groups, one-to-one interviews. For the land maintenance appraisal, we were able to submit data taken from a survey which had 600 respondents who had received lenalidomide maintenance, which is clearly a very impactful statement of patient experience. We also do a lot of policy work in the access to treatment area. So recent successes, and a couple of these unusually have involved NICE appeals, which we hadn't done for a very, very long time. But we have found ourselves in a situation where over the past year and a half or so, we have had a couple of NICE appeals. So Dara Cyborg, which initially was rejected by NICE, we lodged an appeal to that, and the decision was subsequently changed. We advocated as part of the selinexor appraisal. Again, elranatamab, that wasn't a full appeal, but we lodged a letter stating that we objected to the pomalidomide restriction. That decision was withdrawn as a final decision, went back out to consultation, and I'm glad to say, as we now know, that the pomalidomide restriction has been lifted. We were part of the teclistamab appraisal, and as others have mentioned, we also, along with UKMS, appealed the isatuximab, pomalidomide and dexamethasone decision, and that is going back to committee. I have to say, if you have to do appeals, it's nice to have them upheld. I'd much rather not do appeals. They're a very great deal of work. And so it's not something that we do lightly, and we only ever do it if we really feel that we have strong grounds. Finally, I want to talk a little bit about our lived experience and clinical practice work. So hopefully everyone in this room is aware of our, I am going to toot our own horn here, really excellent information and support services. And one of the things I want to highlight is that that's not just about information and it's not just about advice. It is about powering patients to express themselves and to have better conversations. One of the things that my colleagues on the Infoline, Ask the Nurse and Peer Buddy service do incredibly well is help patients to think about how they are going to speak to their doctor. How are you going to frame a conversation that means that you get the answers that you need? So I think patients are very much at the heart of that service. We have our clinical service excellence programme, which is a hospital accreditation programme. Again, I know there will be many people in this room who are familiar with CSEP. We're really delighted that you're part of the effort. We have a total of 62 accredited hospitals at the moment. And here's some of the feedback we've received from hospitals involved. And again, in terms of patients being at the heart of decision making, one of the fundamental parts of the CSEP process is that we run a patient survey. And the hospital also does their own assessment, and then we put the two together and we see where they align and we see where there are gaps. And as we can see from one of the comments, that really has helped teams on the ground understand how they can better meet patient need. Finally, this is sort of hot off the press, except it's a digital platform, so I'm not sure if you're allowed to say hot off the press. Hot off the digital platform is our new HCP hub. That has just in the past couple of weeks been what I think the kids call soft launched. So some of you may be aware of that. Some of you may have received invitations. And it's a new digital platform which is really there as a space for collaboration and learning for all healthcare professionals. So nursing colleagues, allied health professionals, pharmacists, this is a space for you. It is a safe space which is for HCPs only. It's not a space for patients. And what we want to do there is, first of all, make all of you aware of the range of what we do at Myeloma UK and how that can help you, but also really bring together what we are calling a community of clinical change makers. So, as we've heard here, there's huge diversity and huge innovation happening at ground level. How did people actually deliver that? And some of that is about having the right protocol for an ambulatory bispecific service, but some of it is about saying, how did you make that business case? Who did you actually talk to? Who did you get on side? And those are the kinds of learnings that we want to share on the hub. So again, this is a list of the kind of things you can expect to see on the hub, and please do Google and sign up. In summary then, we at Myeloma UK want to be and see ourselves as a meeting point and a catalyst for change, because what we bring together is that understanding of patient need and priority with our close connections to the clinical and research community. And bringing those two things together, I think can be hugely successful in delivering change. Thank you.